Okay, good morning, everyone, and welcome to today's session at Breakfast at UMHealth 2021. Today, we have two exciting lectures lined up, and it is my pleasure to introduce the first speaker, Dr. Ek, a colleague and friend of mine from the Pediatric Respiratory Department. Today, her lecture is entitled Challenges in Managing Children with COVID, which is an extremely apt title for her as she is the head of the Pediatric COVID Task Force and has been working really hard during this pandemic. So, Dr. Ek, would you like to take the floor?
Right. Thank you, Prof. Anna, for the kind introduction. Okay, I will share my screen. Can you all see?
Yes.
Okay. All right. Good morning, everybody. Hi, I'm Ek from Pediatric Department. Today, I'm going to talk about challenges in managing children during COVID-19 pandemic. As this is the outline of my talk. I'll start off briefly on COVID-19 in children, and then share cases in our children. Then lastly, talk about the challenges. I'll focus on co-infection, psychosocial issue, and a bit on immunizations. As everyone knows, our year 2020 started off with a pandemic that changed our lives totally. To date, it's about 130 millions people around the world have been infected by this virus. In Malaysia, we have gone through a year of COVID with different degrees of lockdowns. And till today, we are still have to live with this COVID-19. Okay. What are the differences in pediatric COVID-19 from adults? We know from the data shows that children represent 1 to 5% of all the confirmed cases from those reported data. The clinical presentations are similar to the adults, but generally pediatric patients had milder disease, better prognosis, and lower mortality. Many of them are in fact asymptomatic, but may contribute to transmissions. And how did they get the disease is mostly secondary transmission within the family. To date, vaccines are available, but not authorized in children yet. The disease can be categorized into 5 stages, from asymptomatic, mild, moderate to severe and critical. And until today, there's no specific treatment for this disease. There are some possible factors that could explain why children get milder disease. One could be exposure factor, as most of the countries close schools and keep children at home, so maybe they have less exposure to the virus. And host factor could be due to lower function of and maturity of the angiotensin converting enzyme 2, as this is a cell receptor for the virus. Another thought is actually, could it be strong innate immune response due to the trained immunity, since these children are already exposed to many vaccines and had frequent viral infections. Next, I would like to share some data in our department. During the first and second waves, there are only one confirmed case that admitted to our ward. And we only started to receive more cases during the third wave since October 2020. We were started off with 3 beds, but then had to extend to a full COVID ward since end of last year. In UMMC, we screened these children with positive COVID contact, either they are symptomatic or asymptomatic. And for those also who has no contact, we screen SARIs and also those going for surgery. As of end of March, we had 109 confirmed cases, and over 90 of them actually had either asymptomatic or had only mild disease. Only 4 required ICU care, 3 with comorbidities, and 1 had cold infection. As you can see the data here, we show the December to March this year. Uh, since school opening in March and kindergarten start to open and lifting of the MCO, we can see rising cases of SARI. But good to know that we have yet to see, we have not seen a surge in COVID cases. There are many challenges to manage children during this pandemic. Because their routines are disrupted, a lot of things are being affected. I will focus on a few issues here in my next few slides. I'll start off with cold infection. I would like to share a case that we managed by our Peace ICU team. This is an 18-month-old Indonesian boy presented with acute stridor, cyanosis, and severe respiratory distress. His saturation on arrival was only 76%, and he fitted once at the emergency unit. He was initially treated as severe viral croup. Despite medical therapies, he had to be intubated and transferred to ICU for further care. Further history, actually there was no positive contact history with COVID-19. He was taken care by a babysitter when both parents went to work. This babysitter also looked after a few other kids that one of them had fever and cough. Parents were asymptomatic throughout, and the COVID swab were negative. The first swab of this boy, it was a nasal and oral swab. We sent both our conventional way and also we asked for a biofire to give us a quicker results, because of the atypical representation of this boy, we suspect it could be other viruses. And true enough that these results came out that besides the SARS-CoV-2 virus being detected, there was also another virus called respiratory syncytial virus was detected. And a CT value from the usual swab turned out to be 34, which is a high CT value. That could tell either could it be the beginning of the infections or towards the end of the infection. Looking at the whole picture, we suspect it is more likely towards the end, and the current presenting symptoms may probably more likely due to RSV than the coronavirus. So we repeated another sample 2 days later, and the results came out that the RSV is still positive. This is using an immunofluorescent test, and SARS-CoV-2 was not detected. This boy has persistent fever in the ward, and the blood results show some rising inflammatory markers. So our concern that time, could it be a multi-system inflammatory syndrome in children, short-term as MIS-C? In a bit on this hyperinflammatory syndrome, it was first reported in May last year by the UK group when they noticed there's a cluster of children present with hyperinflammatory shock that following COVID-19 infections, typically 2 to 4 weeks after the infections, and all of them progress into refractory shock, eventually require anthropic support. So these conditions was later termed as multi-system inflammatory syndrome. And it was defined by CDC as any young adults or children less than 21 years with fever and evidence of inflammations, severe illness with multi-organ involvement, and no alternative diagnosis, and with evidence of SARS-CoV-2 infections. So in this case, there are RSV as well. So it's very, I think it's hard for us to be sure whether this is just a co-infection effect or is a MISC effect. But good things about this boy is he recovers after we started systemic steroid and antibiotic. Uh, fever settled. He was extubated a few days later and discharged well. We sent before discharge. We sent his blood for SARS-CoV-2 antibodies, and it turned out to be positive, both the mother and children. That means that they were really infected by this virus. So co-infection of the SARS-CoV-2 virus with other pathogens has been reported in, both in adults and children. It can raise difficulty of diagnosis, treatment, prognosis of COVID-19, and even increase the disease symptoms and mortalities. Probably this is what happened in this case. However, there are still limited data on the impact of co-infection to the disease course in children. Next, I would like to share some challenges in this managing the psychosocial issue. There's a story of a family of 7 members. The family had interstate travel to attend a gathering in mid of December. A week later, the father was diagnosed to have COVID-19 and got warded. The other family members were screened. Mother and 3 out of 5 children were also infected. However, 2 other children were tested negative in their initial swab. Because of there's no other carers at home, mother and all children had to be warded as per guideline at that time, and they were warded in a pediatric ward in a family room. All of them were asymptomatic. A week later, another girl, 6-year-old girl, was tested positive on a repeat swab, even though she's asymptomatic. So all had to stay longer than what is required because of the child. So the rest also had to stay back. The mother had to stay back to look after the child. Even though they are COVID positive, but children they're apparently well. They're still energetic. They were playing in the room. They were messing up the room. And mother really got depressed that time. So there's a lot. We talk to the mother. There's a lot of talking and counseling with the mother. We also offer the professional psychosocial support. We give toys, many toys to the children. So they discharged well. Not surprisingly, this is how the rooms look like after discharge. If you can notice, we lost the cupboard and this cupboard door. So later, MOH introduced the new guidelines in mid of January, and this really helped with this kind of situation. It's stated in the guideline that asymptomatic and mild cases can be treated at home. So children with they can have option to stay at home and to be monitored by the healthcare professionals. This relieve a bit of their tension and stress because of the disease. Okay, what about children out of hospital? They are not really spared. There's many articles, stories talk about how COVID-19 has had a negative impact on children. And UNICEF reported that 4 million children affected by school closure and because of the shutdown, and also 500,000 school children from low-income countries cannot access the supplemental school meal program. So I would like to share this article on school closure, what is the impact during outbreaks. Okay, this is actually a rapid systematic review, not just on the COVID-19, but also the previous coronavirus outbreaks like SARS and Middle East Respiratory Syndrome. About 16, 7 of them published. The rest is still in preprint. It shows that all these data shows that school closure did not contribute to the control of epidemic. And the recent modeling studies of COVID-19 predict that school closure alone would prevent only 2 to 4% of deaths, much less than other social distancing interventions. So this gives us a thought that whether school closure is a good idea to continue. And these two authors from UK share the opinion that school closure may have only a relatively small contribution in preventing the spread of this virus when compared with other measures. So they think children should be more than passive recipients of our concern. We need to build a new normal that is a kinder, more inclusive and equal society in which today's children are to be active members. Though there are many challenges that children have to face during this pandemic, but there are also some opportunities for children. Um, they have the opportunity to build their resilience, their reduced academic stress, more time with family, less access to substance, also more opportunity to have access to healthcare technology. And as we all know, telemedicine is developing in many centers. So how can we support our children? I think we should give them more attention, encourage healthy habits, keep a regular routine if possible, provide information, talk to them, reassure, and teach them coping skills, and keep the family connected. Last bit, I will talk about immunization. Children were excluded from the initial clinical trials on vaccine, so there are no data regarding the safety and efficacy in children. And currently, the vaccines are only authorized for adults and teenagers who are at least 16 years and above. And it is estimated that to achieve herd immunity, we need to have at least 70 to 80% of our population being vaccinated. So from the our statistic shows that in our country, nearly 30% of Malaysian populations are children. So if we exclude these children and adding to this adults who cannot or do not want to be vaccinated, can we still achieve a herd immunity? That's something to think about. And so good news is we have a new trial coming up that involve pediatrics. So hopefully in a near future, we'll be able to have more data on the safety and efficacy of vaccines in our children. But even with vaccines which is available for safe for children, should we maintain a COVID-19 vaccine for them? It is quite difficult to justify requiring vaccines in children for a disease that appears to be mild in most children, especially if their role is minimal in spreading the infection. So we need more data on this. Some thoughts on the future directions for research. I think the role of children in community transmission of this virus we need to have more data. We need to know more about the factors that causing severe disease in children, and what is the impact of co-infection, what's the role of disinfection or vaccination and on the children infected with COVID, and of course the long-term impact of COVID on child health. I'll end this talk with some take-home message. Just children are still at risk for severe illness and complications of COVID-19. We need to consider co-infection and screening for other respiratory pathogens. We should also provide psychosocial support to both children and their parents, guide them through a new normal life. And last but not least, all of us, if not contraindicated, should get vaccinated to protect ourselves and protect our children. To end this, I would like to thank the teams listed here for their kind support and helps in managing our children. With that, I thank you for your attention. stay safe, stay healthy, and play a role in the fight against COVID. Thank you. Okay. I end my talk here. I'll pass it back to the moderator, Prof. Anna.
Time. We have a couple of minutes. Do you want to share with us about the your experience with Cosmos? That means doing home monitoring, doing a home monitoring for the children with Cosmos. Maybe some people may be worried about safety, and what has been the experience so far?
Okay, thanks for the question. Before actually we started, just now I showed that Cosmos thing. The Cosmos app is actually an app invented by our UMIT team. It was initially started off as a research tool to monitor children with suspected COVID. The PUI, the PUS group. Not confirmed cases because at the beginning of the pandemic, everyone's confirmed COVID need to be warded. So the idea of monitoring, I think all the clinicians, including the adults, physicians, they probably agree that a lot of all these patients, they had either asymptomatic and had very mild disease that need not to be occupied the wards. During our third wave, we have issue with the base. I think this is probably more obvious in adult side, even in our pediatric side, because of a few outbreaks in our own hospital involving our staff. So the surge in the numbers of COVID cases, they made us think about, like, can we monitor these children at home? But because of the SOP, we could not do that. So until we have, but we have been talking about that even before the KKM guidelines was out, and we with the help of the UMIT team, we managed to did some modification on the questionnaires on the apps and use it for confirmed COVID cases. This is actually using a telegram for the carer parents to report, or the patients themselves to report their own condition daily, 2 to 3 times a day through telegram. And there will be a dashboard to be monitored by the clinicians, so that if any of the warning signs or red flags that's suggestive of worsening of the condition, then they will be contacted and arranged for admission. That's actually how we monitor them using the app. But meanwhile, also we actually had a few cases that we could, because of the technology, the parents that couldn't refuse to use that. So we have a few that actually we do phone calls as well to monitor them daily from distance. The experience is that actually parents and children, they are happier, and so far most of them actually can be monitored and need not to be warded. One or two, from our experience, we only actually monitor about 11 of them. That's only one needed to be come in because of develop of fever, but otherwise actually they're all well.
Yeah, so that means that Cosmos and home monitoring is actually very suitable for children, and that actually reduces the psychosocial stress that many of these parents actually face. Okay,
Yes.
I got one more question.
Sorry, forgot to mention. Of course, actually, we set our we have a preset criteria before we screen through first the specialists on call, screen through the cases first before we allow them to be home monitored.
Okay, so I got one question from Subhash. She's asking whether or not you think that vaccination in children is the way to go to end the pandemic. So what do you think? Do you think that's going to help ending the pandemic?
Good questions. As I think I mentioned in the slide,
Yeah.
whether even we have vaccine, let's say now we have vaccine, but it's only 30% of our population, I mean of our populations has registered. So if we can't do this on adults,
Adults
we
better
can't
to
achieve 70-80%. Just
maybe
wondering how we can achieve 70-80% for children.
for children.
Yep.
Yeah, so the way to go is actually to vaccinate the adults as they are the
First.
spreaders. Yeah.
Yeah.
Okay. For your Cosmos, another question for your Cosmos. Any age? What was our age limit? For Cosmos home monitoring.
Okay, there's some data shows that to infant younger than 6 months, one of the Chinese paper say that they have a higher risk of getting severe disease. So we set our age at 1 year and below had to be warded. Anyone with comorbids also had to be warded, and we only use for our staff at that time. It's not because the
Yes.
KKM have their own
Mm.
SOP to monitor these children. So we only use Cosmos for, so far we only use for our staff children.
Okay. Alamak. How did you? Okay. Okay. So last question, quick one, 2 minutes. How did you calculate the data that says children are only less than 5% of the spreaders? I think this was something that was in the article, isn't it?
Yeah, this was most of the article that try to calculate
From
that
epidemiology data lah.
epidemiology data.
Yes, yeah.
I think
You do
because most of the
contact tracing.
countries practice school closure, lockdown. Definitely, most of the country, I think, in fact, they all reported that children are less infected. Well, we will see since schools open now, we probably can have more data on when we are back to our usual school life. Then maybe we have new data on this.
Yeah. Okay. Cool. Okay. Excellent talk. I think nobody can underestimate the psych. In fact, for pediatricians, it was not the illness per se, but the psychosocial impact as a parent, as a pediatrician of COVID, and the impact still goes on. Okay. So thank you so much, Ik. Thank you for keeping your time, and thank you for those interesting data.
Thank
Okay.
you.
So I'm gonna
Thank you.
thanks. So I'm gonna pass the floor over to the next speaker.